Welcome back to Straight Talk About Health and Wellness. My name is Mary Henderson, and I am your host. All right, today we're going to be talking about a topic that affects all men. And Straight Talk About Health and Wellness, we are here to aspire, to educate, all right? And so you have something that you can live your best life, the information that you can live your best life. All right. Today we're going to be talking about prostate cancer. All right. Very important. All right. According to the American Cancer Society, there will be 1 out of 8 men that will experience prostate cancer in their lifestyle. So this show will be to educate all men that are out there, educate the young men. And also, today you need your pencil and pad, all right, because you probably will need to take notes so you can remember. All right, today we have a very important guest. Of course, we always have important guests, but today is really special. All right, we have Dr. Larry Smith. All right, so I'm gonna bring you him in a few minutes, but I want to remind everybody that Straight Talk About Health and Wellness, we are here to inspire and educate. We do not take the place of your PCP. What do I mean when I say PCP? Your primary care physician. All right. If you do have some concerns, have that conversation with your primary care physician, which that could be a nurse practitioner, it could be your therapist, most times it's your medical doctor. All right. So we're gonna jump right in this. All right. I'd like to introduce you, Dr. Larry Smith, PhD hematologist. Good morning, Dr. Smith.
Good morning, Mary, and thank you very much for this opportunity to speak to you and to your audience. I'm looking forward to talking about prostate cancer.
Thank you for making the time to come. I appreciate it.
Thank
With
you.
your busy schedule, too busy schedule. So, as I'm gonna ask you to tell us a little bit about yourself.
Well, as Mary has indicated, my name is Dr. Larry Smith. I have a PhD in cell and molecular biology, and I've done postdoctoral studies in gene therapy as well as experimental hematopoiesis. A lot of my background is in hematology itself. I was the director of the hematology laboratory at Memorial Sloan Kettering Cancer Center some years ago, responsible for a lot of hematology that came out of the laboratory, as well as coagulation. I've been a worldwide speaker in coagulation. I've penned a number of articles, edited books, etc. And about 10 years ago, I moved out to the Bay Area, to San Jose, to work for Abbott Diagnostics in their hematology division. That's about it in a nutshell.
That's a lot. That's a lot. So you're in the Bay Area.
Yes, in
You
the
in,
Bay Area.
oh my goodness. Is it raining down there?
It did rain last night, but I went out for Starbucks about 30 minutes ago, and it wasn't raining, but it's going to rain a little bit because this is the beginning of our rainy season.
It is. It is. It's raining. I'm more
Okay,
northern. So I'm in Northern California also. It's been raining, a little raining this morning. So
okay,
it's
okay,
that
all
time of
right.
year, like you said, but it's really sort of cold also.
It is. It's a little chilly.
Yeah, it's time to get your blanket out and eat your popcorn. Well, Dr. Smith, we're gonna jump right in it.
Sounds
All
good.
right,
Uh,
because I have been waiting for this interview for a while because people need this. We need to educate and be aware of
yes,
certain things so we can protect ourselves. So
yes.
I'm gonna ask you the number one question for the day. What is prostate cancer?
So that's a great question. So let me start out by first giving a definition for cancer, and then I'll pivot over to prostate cancer. Cancer then can be described as an abnormal growth and proliferation of an otherwise normal cell. And for whatever reason, and many of these reasons have been identified, this normal cell goes haywire. And then the cell itself and the body that the cell is located in has lost the ability to apply the brakes to this particular cell. So this cell starts to divide and replicate uncontrollably, and we can't stop it. Either the brake pedal is missing, or there's something that interferes with the brake pedal, or there's no brake pedal whatsoever. But that's what cancer is. Now, if we just move this scenario over to a normal cell in the prostate gland, then we have this normal cell that just goes haywire and it starts to replicate and divide uncontrollably.
I see. So my next question should be what is a prostate, maybe?
Well, the prostate gland itself is a little organ about the size of a walnut that's located just below the bladder in men. And it's responsible for adding liquids to semen when there's an ejaculation. The other thing that happens in the prostate is there's a special little tube that passes through called the urethra that connects the bladder to the outside of the body. And so this urethra actually passes through the prostate. Now, the prostate doesn't do anything to this urethra, but if the prostate becomes enlarged, it can constrict and decrease the flow of urine, etc., that's passing through this particular tube that goes through the prostate gland.
I see. Some people don't understand the anatomy and physiology, the function of the
Yeah.
prostate. What are the risk factors for
There are
developing prostate
there,
cancer?
there are a number of risk factors that have been associated with prostate cancer, but the main risk factor or symptom, the main risk factor, there are several risk factors that I can really talk about. Three of them that come to mind are risk factors that we call unmodifiable. So that means that there is nothing that we can do in order to decrease the risk that these particular factors might contribute to developing prostate cancer. The first risk factor would be age. There's nothing we can do about age. We're just going to
Mhm.
age as we
It
go.
comes.
But
Yeah,
yes, but what we find is that the frequency of diagnosing prostate cancer begins to increase around the age of 50. That's when we really start seeing an increase in the number of cases. We often consider cancer a disease of older age anyway. Now, that's not always true, but that's what we see normally. And when you look at prostate cancer, most of the cases are actually diagnosed in the mid 60s. So let's say starting at 65 or so. And part of that might be because we start to screen patients more often as they get older as opposed to when they're younger.
I see. So does family history have anything to do
And
with it?
so that brings me to the second risk factor, and that would be family history. A number of studies show that when an individual has a first degree relative, that would be, let's say, a father or a brother, then
Mhm.
their risk for developing prostate cancer is two times what we would see in the general population. Now, if that particular individual has two first degree relatives, let's say a father and a brother, then their
Mhm.
risk jumps to about five times what we would see in the general population. But let me just say one other thing about a risk factor. A risk factor is nothing more than an increased propensity to develop a disease, and in this case, to develop prostate cancer. Now, one other very important thing to mention here is that just because a person has a risk factor, that does not mean that they're going to develop the disease. However, when we look at the number of cases in these individuals with risk factors and compare them to the general population, then they have an increased frequency in that comparison.
Good to know. Does diet have anything to do with it?
Well, diet would be one of a risk factor that the evidence is not very strong sometimes, but we
Mhm.
do believe that if we eat well, then we can reduce the chances of developing cancer, any kind of cancer, or any kind of chronic condition. And certainly,
Mhm.
if we're being treated for cancer or so, then if we modify some of our habits, such as good eating, etc., then those are
Mhm.
also associated with better outcomes when it comes to that disease process. But one other thing I'd like to mention about these unmodifiable risk factors, we
Mhm.
mentioned age, we mentioned family history. I'd also like to mention race. Race is another unmodifiable risk factor that is associated with cancer. A number of the studies show that African American men are present with more cases of prostate cancer than Caucasian
Mhm.
men. In addition, African American men are more likely to have a first degree relative with
Mhm.
prostate cancer. So that becomes another strong risk factor when it comes to developing prostate cancer, especially in the African American community.
I see. So if there's cancer in the family, does it need to, if are they a risk if it is prostate cancer, or can it be any cancer?
It can really be any kind of cancer because there are sets of genes that we can inherit from our parents,
Mm-hmm.
and if those particular genes are mutated, then they may not be able to shut off a developing cancer that might be developing. Now, this becomes very important when we start talking about genetic testing, because sometimes it really is very important to know if you inherited one of these particular genes from your parents, because that the genes come from our parents. And if we have inherited one of these genes and it is mutated, then
Mm-hmm.
certainly we feel that we might pass this gene on to our children, and we
Mm-hmm.
can really do something about it. We can have our children start to get screened at an
Mm-hmm.
earlier age. And
Mm-hmm.
and we know also that in some cases, people have inherited these genes, let's say in the case of breast cancer, and
Mm-hmm.
prophylactically, they may have had a mastectomy in order to reduce the chances of that cancer developing. That's not necessarily the case with prostate cancer, but there is a lot that we can derive from some of this genetic testing and knowing whether or not we have these genes. And just for the record, these are
Mm-hmm.
called germline genes as opposed
Mm-hmm.
to somatic genes that appear
Wow.
later in cancers as they begin to change, to mutate and change.
My goodness, this is a lot of information. Good information. Good
Well, thank you.
information. Okay. Can you explain the importance of screening and what is a PSA test?
That's a very good question as well. Screening is very important because it allows us to identify a cancer long before any symptoms can occur. And what do we know about this? If you identify the development of a cancer and diagnose it early, then the
Mm-hmm.
outcomes are much better. We can even say that it's possible to cure the cancer if we catch it
Mm-hmm.
in its early stage. Now, one thing that we know about African Americans, especially with prostate cancer, is that they're more often diagnosed at a later stage of disease. If you're
Mm-hmm.
diagnosed at a later stage of disease, that requires a more aggressive form of therapy.
Mm-hmm.
What happens to your quality of life? It goes down.
Mm-hmm.
And if you start treating that cancer at a later stage in life, that means that your chances of dying actually increases. So, being able to screen and catch a cancer very early is very important. Now, when it
Mm-hmm.
comes to prostate cancer, there are actually two screening tests that are out there. There's the PSA, or we call this the prostate specific antigen. Now, this is a very
Mm-hmm.
simple test, it's a blood test, so it's not a painful process. It's nothing more painful than just getting a needle stick in the arm and getting some blood
Mm-hmm.
drawn. But but this PSA test then would just has been associated with prostate cancer, because when the levels of PSA, this protein that circulates in the blood, is elevated, it's found to be elevated in prostate cancer. Now, it is
Mm-hmm.
not specific for prostate cancer. It can be elevated in a number of other urologic conditions, such
Mm-hmm.
as, let's say, a UTA or benign hyperstatic hyperplasia of the prostate. It can
Mhm.
be elevated in infections. If you
Mhm.
go out and ride your bicycle, it can be elevated. So when an elevated result comes back, physicians must interpret that elevated result along with other conditions that the patient might describe.
Mhm.
Um, Now, the PSA is associated with there's some good benefits as well as some negative benefits with any of these screening tests. The PSA can result in overdiagnosis just because someone gets an elevated number and they
Mhm.
don't take other issues into context when they're evaluating the result. It might
Mhm.
lead to someone getting a diagnosis of prostate cancer. Now, the tumor, if a tumor is present, the tumor could
Mhm.
be clinically insignificant and may not require anything. Um, the PSA test is also very good because, as I said earlier, it allows for early diagnosis before any kinds of
Mhm.
symptoms have occurred. It's also associated with some negative aspects. There are
Mhm.
false positives and false negatives that can be
Mhm.
associated with not only the PSA test, but with other tests in general that are done in the laboratory. But this should not be a grave concern of any of us who get this kind of testing because scientists work very hard to reduce those false positives and the false
Mhm.
negatives. Now, a false positive just simply means that a person has an elevated result, but they don't really have cancer. And a false
Mhm.
negative would be that they have a normal result, but they really do have the cancer. But
Mhm.
again, when these tests are being developed, scientists really work very hard to reduce the number of false positives and false negatives with any of these tests. But if there's ever a concern, it needs to be discussed with the healthcare professional who is actually ordering the test. In addition
Mhm.
to overdiagnosis, there can also be something that's called overtreatment. If you have a very zealous physician, they might say, "Oh, I see this elevated result, so I'm going to order
Mhm.
this biopsy." Well, a
Mhm.
biopsy comes with its own set of goods and bads at the same time. And
Mhm.
so one has to take all of this, in conjunction with other clinical findings in all of these patients. Um, we talked about false positives. We talked about overdiagnosis. We talked about
Mhm.
overtreatment. But the PSA exam itself is really very good because it's used very often when we're looking at things like risk assessment. How bad
Mhm.
is this really tumor? Do we have a very high prostate PSA antigen, and is it coming down? It's
Mhm.
used to monitor therapy. We do some kind of therapy on these patients and follow the PSA. If the
I
PSA
see.
is coming back down to normal, then we feel like the treatment is working very well. And so
Mhm.
it can serve somewhat as a follow-up marker to let us know
Mhm.
how well our treatment has been.
I see. What would be the signs and symptoms if a person was having problem with their prostate?
Some of the signs and symptoms that have been identified. Now, again, prostate cancer, the most significant symptom is really no symptom whatsoever.
Mm.
But now,
Mhm.
later in the disease, patients may experience difficulty urinating. They may
Mhm.
experience an increased frequency for urinating. They may experience a weaker urine stream.
Mm.
Certainly, if there's any kind of blood or any kind of pain that's
Mhm.
associated with urination, these have been associated with prostate cancer, especially in some of the later stages. But again, these are not specific for prostate cancer, and they can be seen in other urologic conditions. But the point that I think people should really know about these symptoms is that if they do have these symptoms, they should discuss them with their healthcare professional. Now, not at the next annual visit to the HCP, but they
Mhm.
should call in and get these and talk about these, as soon as possible.
Mhm.
Symptoms can occur, but we need to talk about them. But prostate cancer doesn't have any, quote, symptoms that set it apart from some of the other urologic
Oh, I see.
conditions.
Mhm. I see. So after you've been diagnosed with prostate cancer, what would be the treatment, the various
Well,
treatments?
after diagnosis with prostate cancer, so you would go through screening. So that would be either a PSA, and one other screening test that I did not
Hmm.
talk about was the digital rectal exam.
Hmm.
This is where a physician actually inserts a finger into the rectum and just feels the surface of the prostate to kind of look for whether it's a smooth surface or is it a
Hmm.
bumpy surface. Can they feel any kinds of protrusions against the wall of the prostate,
Hmm.
things of that nature. Um, uh, um, so after those two particular tests, then a physician, if there's a high suspicion for prostate cancer, would order a confirmatory test, which would be the biopsy. In the
Hmm.
biopsy, a needle would be inserted into the prostate gland, and a physician would take out various samples and send those samples of tissue to the pathology laboratory, where a pathologist would look at those tissue samples and determine if there are abnormal cells present in any of those tissue samples. Now,
Hmm.
based on that, there will be a risk stratification. This is where physicians would look at the cells that are there and determine, are they located in one area of the prostate, or are they beginning to metastasize
Oh, I
to
see.
other
Hmm.
regions? Certainly, if they are beginning to metastasize to other regions, then we might need a more aggressive approach in order to get them. Whereas if they're just in one location, then maybe we don't have to do as much. And then the
Hmm.
second approach will be a type of um, a risk assessment. So we want to look at those cells and compare the Gleason score along with, I'm sorry, compare the PSA along with the Gleason score. So the
Hmm.
Gleason score then would look at these cells and see or determine how aggressive those cells look. I don't like the word aggressive. I like to say how ugly the cells are.
Hmm.
And so if I have X amount of ugly cells compared to the normal cells, those ugly cells are more aggressive, and they certainly may jump into a real
Hmm.
severe cancer more, more much quicker. So by looking at all of these things together, that PSA,
Hmm.
how high it is, how ugly those cells look, and where the tumor is actually located, then a physician would decide on what type of therapeutic approach would be necessary in
Hmm.
order to treat those patients.
Oh, I see. So he takes biopsy,
He would
then
take a
they look at the
biopsy.
cell.
Yeah, and pathologists would look at the cells and send a report back to say these cells are look like they're just in one location only, and
Hmm.
they look pretty. So if they look pretty, then there might be a watch and wait approach. Whereas
Hmm.
if the cells are very ugly, we may need to get in there and do something right away. And certainly, if they're beginning to metastasize, going into other areas of the body, into lymph nodes,
Hmm.
etc., then
Hmm.
we need to be a little more aggressive because we don't want these cancer cells to spread.
Spread. Yes, yes. What are some of the treatments?
There are a number of treatments. And again, each of these treatments that I'm going to tell you about have benefits as well as downsides. So all of
Has
these
a
need to
flip
be
side.
discussed. Yeah, they all need to be discussed with your healthcare professional
Hmm.
before taking them. But even though they may have some downsides, we're very good at giving patients things to take care of those downsides. So that does not have to be as concerning. It's
Hmm.
better to go and get the treatment than to say, no, I don't want my hair to fall out. One of the
Yeah.
things you can do if your hair falls out is wear a wig. There's nothing wrong
Hmm.
with that. But in terms of some of the treatments, again, if the tumor is not aggressive, if it's not ugly looking, etc.,
Hmm.
and it's in one location and does not look like it's going to move anywhere, then there might be this watch and wait approach that's called active surveillance.
Hmm.
Certainly, there's surgery where someone can go in and cut the tumor out, but we know that surgery has its good benefits because it really works, and it has
Mm-hmm.
its bad benefits. It can result in bleeding or infection. But again,
Mm-hmm.
I can give you something for the bleeding, I can give you something for the infection. So that shouldn't be a great concern.
Mm-hmm.
There's radiation therapy. This is where a beam of radiation is directed directly to the tumor to try to, let's say, blow it up, if you will. If I can get that bad guy out, then
Mm-hmm.
that's a good thing. And radiation therapy does work. There are some downsides to radiation. Many patients complain of this burning sensation, but that doesn't have to stop a patient from getting radiation therapy because they
Mm-hmm.
can give you something for that burning sensation.
Mm-hmm.
There is something called androgen deprivation therapy. We all
Mm-hmm.
know that if a person develops a tumor, those cells have to eat something. So if
Mm-hmm.
we can deprive those tumor cells of, let's say, testosterone, then they can no longer grow. But now that's associated with a number of mood swings. But you can certainly take medications for mood swings. And it doesn't have to be in the form of a pill. It can actually be sitting down talking to someone. So there are mitigation strategies. We all know about chemotherapy. Chemotherapy
Mm-hmm.
is like a poison that goes into the body, but
Mm-hmm.
chemotherapy works. It can stop
Mm-hmm.
some of these dividing cells. Now,
Mm-hmm.
we all know some of the negative aspects of chemotherapy, the nausea, the feeling nauseous, the hair falling
Mm-hmm.
out, the anemia, things of that nature. But
Mm-hmm.
again, there are mitigation strategies for all of those. Two newer forms of therapy that I think are really very interesting are targeted therapy. So, targeted means that we're going to develop something that goes directly to our target. So, if
Mm-hmm.
we do some genetic testing on some of these tumors to identify the exact mechanism that's making them grow, then scientists can develop a targeted therapy, let's say one pill or so that inhibits this one particular activity. It
Mm-hmm.
does not affect all of the other cells that are around, and that's key when it comes to treating a tumor. And it would just interrupt that particular mechanism. So
Mm-hmm.
that's a targeted therapy, kind of like we might call that precision medicine or tailored. I mean, you go get a suit that's tailored that fits
Mm-hmm.
every curve on your body. And
Yeah.
so that's what the targeted therapy would do. And then there's also a new kid on the block. It's been around for many years, but we've kind of brought it back into the realm of things, and that's immune therapy. And this is where we take cells in your own body, your own
Mm-hmm.
cells. We
Mm-hmm.
may take them out and we train these cells to go back in and recognize that tumor and actually kill that particular tumor that's around. And so all of these therapies are effective in their own way.
Mm-hmm.
They may
Mm-hmm.
not work for every different case. So so they may differ in terms of their
Mm-hmm.
effectiveness for certain tumors, but they do work. They each come with their own sets of benefits as well as negative
The
aspects.
flip side. Yeah.
Yeah. So, but the main thing is to discuss them with the healthcare
The
professional.
healthcare professional. You have mentioned the other side of the treatment. Is there any type of treatment for mental health?
For mental health, there's a lot of treatment out there that does not always have to involve taking a pill to get rid of it. Certainly, sitting down and discussing what issues that may be causing this anxiety, just being able to talk about it can be very effective in terms of handling the anxiety that's associated with some of these things.
Mm-hmm.
And we don't often talk about that. And often there's a stigma that's associated with that. And certainly we have to find ways to reduce that stigma to get people to just go talk to a counselor. There are a number of counselors around. And actually, when a treatment plan is made for a patient with cancer, it should
Mm-hmm.
involve a multidisciplinary team to start with. So that would also include some type of counselor to help with those particular issues as well, because we want to treat the whole body and not just the tumor. Um, and certainly there should be some shared decision making between
Hmm.
the patient, between the physician, as well as the family or significant other. You
Hmm.
notice I mentioned those androgen deprivation therapy might involve mood swings. Well, if you're married to someone and you live with them, you need to understand the spouse or significant other needs to understand the
Hmm.
mood swings. So therefore, they should be involved in this decision making to say, to understand that this person is going to come home and all of a sudden they just might have a mood swing. And so you need to know what that is. And that helps to improve the quality of the relationship. Yeah.
That's correct indeed.
Yeah,
Because some,
I encourage patients that when they go into their doctor, that
uh-huh.
they take their spouse with them. There's nothing that you have not seen. So there's no reason for anybody to be embarrassed. You took this oath to for better or for worse, so it's a shared process. Whether it's prostate cancer, whether it's breast cancer, or anything else, take that significant other in there with you so they can help to understand what's going on and be a part of the decision making process.
I think if everybody knows what everyone's doing, then it won't
Yes,
be any misunderstandings, right?
exactly, exactly,
Yeah.
exactly.
I think some men want to know that after all this is done, where will life go on as usual?
That's a discussion to have with the healthcare professional because I think a lot of that would depend on the type of therapy
Hmm.
that was involved. But certainly life does go on and people become more beautiful.
Hmm. Sounds good.
Yes.
One more question, Dr. Smith. What is the age that men should start taking their someone? I think this may be off topic, but they asked me to ask this. What age should you take your colonoscopy?
Well, in general, we
Hmm.
often think of cancer starting around age 50 as an older person's disease. So if you're talking about a group of people where there are no risk factors, they're
Hmm.
not a part of a high risk group, let's say being African American. African
Hmm.
Americans we know will present with cancer more so than other races. If they're not
Hmm.
a part of one of those groups, and if they don't have, let's say they don't smoke or don't drink alcohol, have these
Hmm.
other associated risk factors, then it may be okay. It may be okay for them to start at 50. But if they have direct relatives with cancer, if they
Hmm.
are part of one of these high risk groups, and really for our African American brothers and sisters, they maybe need to start at a much younger age. I think the
Hmm.
newer recommendation suggests that men, for example, with prostate cancer, if they have a
Hmm.
first degree relative, and remember I said that increases their chances two times out of the general
Hmm.
population, but maybe they should start talking to their healthcare professional and maybe even insisting on screening at the age of 45. And if they
Hmm.
have two first degree relatives, then they need to start maybe at the age of 40. But it's
Hmm.
very important that they dig in for themselves, that they dig into that family history so that when they go in for their appointment, they are better equipped to say, I have this family history, I'm a part of this high risk group, etc. I really
Hmm.
want to get started. Again,
Hmm.
it's a conversation with the healthcare professional and a joint decision that needs to be made, but they do need to start at a much earlier age because if we start earlier, what happens to the outcome? It improves.
Sounds good. Last words that you would like to leave. Thank you so much. Any last
Well,
words?
I think there are a lot of new advances that are coming out when it comes to prostate cancer and many of the other cancers as well. But I think
Hmm.
there are improvements when it comes to screening. There are new screening tests that are out there that certainly can help to differentiate between a tumor that might be clinically insignificant versus a tumor that might be more aggressive. So that's a good thing that we should be happy about. There are advances in this genomic testing. We've gotten very good with this molecular biology, so we can go
Mhm.
in and tell you what the target is, and we can develop a medicine for that target. There are advances in this immunotherapy whereby your body does the
Mhm.
work itself. That's really wonderful because you're not getting something from the outside put
Mhm.
into your body. It's what God gave you to fight the tumor itself.
Mhm.
There are advances in robotic surgery. So, using the robots, I think these guys have gotten very good where they don't snip something by
Mhm.
accident. These robots are good. We can't talk about any of this without talking about AI and the
Yeah,
ability of AI to run
right.
through tons
Mhm.
of algorithms to help
Mhm.
physicians make these decisions. There are advances in radiation therapy.
Mhm.
And then one thing that we did not talk about that I think is very important, uh,
Mhm.
why do Black men appear to have worse outcomes? And, for many, many years, historically, a lot of people tried to ascribe that to race. And there are
Mhm.
not major differences between the races. There may be some subtle differences, but a lot of people have tried to use race to describe some of these biological differences. And that alone is certainly not enough to understand why African American individuals
Mhm.
have poor outcomes. So our understanding and acceptance, we got to accept it and then do
Mhm.
something about it to understand these issues when it comes to socioeconomic barriers, to
Mhm.
institutional racism, to other forms of racism that people just may not be able to recognize. As we understand these and accept these and begin
Mhm.
to do things about these, I think that will really reduce to a great extent a lot of these discrepancies.
Mhm.
One thing that you mentioned that one thing that I did not mention is that often when Black men, this certainly goes for Black women with the breast cancer as well, from the time that they get a diagnosis to the time that they get treatment is prolonged. It's 3 or 4 or 5 months longer than in other races. And
Mhm.
that certainly contributes to a poor outcome.
The
So as
outcome.
we understand these
Mhm.
and work on trying to reduce some of these systemic barriers, I think we can improve the overall outcomes of all individuals.
That's true. Oh, and thank you so much for your information, Dr. Smith. We could
Well,
go
thank you
on.
for
I could
this
listen to you
invitation.
all day.
Thank you so much for this invitation. I get very excited when I talk about a lot of these
I
things.
know. I see. I mean, that's fantastic. We have to have you come back.
Well, I look forward to it. I look forward to it.
We need to come back. All right, everyone. I'm gonna sign off. Okay, this is Mary Henderson from Straight Talk About Health and Wellness. All right. Don't forget to contact your healthcare professional if you have any concerns. All right. So I'm gonna say be blessed, be healthy, and be safe. Until next time.
Thank you.